Class 5, blood clotting, and a little bit of hematology here. There's also several presentations on the blood count. There's a lot of hematology there, but a little bit of a smattering here as well. So let's start with the case. 68-year-old woman. She came into your office a couple of days ago with left lower leg pain. And now you're trying to figure out what's going on. Her past medical history is significant for high blood pressure and hyperlipidemia. And you're trying to figure out, hey, what's going on? She had some recent labs. On her recent labs, her hemoglobin was only 10.9. So she is a little bit anemic. Her MCV was 78, so her cells are a little bit small. Her RDW is 20, so there's a lot of variation in the size of her cells. And her platelets are a little bit elevated. The normal platelet count is 150 to 450 for most labs, and so she's just a little bit elevated. Sometimes this is a nonspecific inflammatory response, but it's definitely something you want to think about. If it's up in the 800 or 900,000 range, you're thinking that she maybe had her spleen out at some point, but this is just a little bit elevated. Her D-dimer is elevated. A D-dimer is a pretty non-specific indicator of clotting somewhere. So you can have somebody that has clotting as it would be expected after surgery. On the other hand, if you've got clotting, you've got to figure out where it is. PTINR is a little bit decreased. The pro time is actually measured and based on barometric pressure, et cetera, et cetera. And so the normal is 12 to 14 seconds or so. It actually varies depending on the pressures. And what we do, rather than actually try to figure out the day-to-day normal, they now publish the ratio of what the normal is versus what the measured is. And so the usual should be, or the normal should be 1. If we have somebody who is trying to be anticoagulated, we'll often shoot for 2 to 3. That would be a DVT or a pulmonary embolus. Someone that has a artificial valve, especially a mitral valve, we might try to have their INR be 2.5 to 3.5. So you need to know why they're on anticoagulation before you know what the goal is. So what are we going to try to figure out? So our learning issues are really going to be around the physiology of clotting and the physiology about hemoglobin and anemia. So let's start with the circulation issues in clotting. Lipids, we're going to talk about this in a separate talk, but basically if you've got a lot of lipids in your bloodstream, there's a chance they're going to deposit. And if they deposit, they'll decrease the lumen size of the blood vessel, but they'll also create some irregularities along the blood vessel. And so these irregularities can cause platelets and other things to stop there and start to develop clots. Some people have varicose veins. Some patients will call them very close veins, which I find humorous, but it is one of those mistakes that people make. And some people will have impaired deep circulation from being sitting for 6 or 8 hours on a plane, that kind of thing. So you figure out whether there's anything structural going on in the veins. A deep vein thrombosis. So a thrombosis is the development of a clot. An embolus is a clot that is moved from one place to another, but a thrombus is a clot that is formed in place. It's important that it be a deep vein because a superficial vein really can't break off and go anywhere. It's going to just basically get caught further along that vein. A deep vein can break off and then travel up through the vena cava into that right atrium and then through the right ventricle up into the lungs. There's also a percentage of people, depending on where you look, the percentage is different, but it's probably at least 5 or 10% of people that have a hole in their heart, either a patent foramen ovale or an atrial septal defect or a ventricular septal defect. And if in that case, the clot can actually pass from the right heart into the left heart. If that happens, it can go from the left heart up into the brain and cause a stroke. So there was a New England Patriots player by the name of Teddy Bruschi that this happened several years ago and got a lot of press at the time. Women get more varicosities than men because of pregnancy. You can get varicosities related to deep vein thrombosis, because if you've got that block, you're going to get these bulging out veins. And you get them also from prolonged standing, and you have to choose your parents carefully, because you also do seem to have a genetic tendency to get them if your parents had them. You can also get them possibly from lifting. The most common varicosities that we really kind of see with that is hemorrhoids. Hemorrhoids are actually just varicose veins of the rectum, and they'll bulge out, and because they're chronically irritated from stool passing over them, they can bleed and get really irritated. Here's an evidence-based practice question for those of you who are in the evidence-based practice tract, and give you an opportunity to probably discuss this on the discussion board. If you've got somebody that has varicose veins, is it better to use TEDs, which are the thromboembolism deterring stockings, which we see used postoperatively, or Jobst stockings, the actual compression stockings? Is it worth the extra cost of the Jobst stockings? So venous and arterial insufficiency, if you have arterial insufficiency, the blood isn't getting out there. So you have pain, pallor, pulselessness, paresthesias. It's a very classic presentation, but it's usually very painful, lots of pain. Venous insufficiency, on the other hand, the blood has gotten out there and the blood has provided its oxygen and its nutrients. It just can't get back to the heart, so it pools out there. So you'll get varicose veins, you'll get swelling, you'll get thickening of the skin, you'll get decreased hair supply. Basically you get some discoloration. So the venous insufficiency has a classic presentation and is much less urgent, of course, than arterial insufficiency. So Virchow's triad. There is also something called Virchow's node. Virchow's node is when you get a node in the left subclavian. That's a rather ominous sign for an intra-abdominal cancer, and supraclavicular node, I should say, rather than subclavian. So if you have a left supraclavicular node, not a good thing. And that's one of the reasons that you really do need to feel those supraclavicular nodes. But if you've got somebody with Virchow's triad, they have blood stasis, I don't know, riding in a plane, increased coagulability, possibly from genetic or other factors, some kind of vessel injury. If you have all three of those, the odds of developing a DVT go substantially up. The normal DVT presents with the signs and symptoms of inflammation, but remember, as far as the redness of inflammation, you're rarely going to see it in a deep vein. You'll frequently see it in a superficial vein, and as we noted, superficial thrombophlebitis is much less serious. There is some feeling of late, though, that maybe if someone has a superficial thrombophlebitis, and especially thrombus, that they may in fact have a deep vein thrombus as well. So there are some people that if somebody has a superficial thrombophlebitis will get a ultrasound, others will not. So the 5 symptoms of inflammation, calor, rubor, dolor, so that redness, swelling, pain, increased temperature, and change in function are the 5 signs. So you may have any or none of those signs. So normally we said that the DVTs will cause venous insufficiency, but we do care because they can break off and they can go to the heart, they can go to the lungs, they can go to the brain. So what do? We do an anticoagulant. Now, it's not going to dissolve the clot, but it'll stop it from getting any bigger, and it will allow the body to break it down over the next several days, or at least stabilize it. So what immediate treatment? So-called unfractionated heparin or regular heparin can be given intravenously. If you have somebody that goes to the ICU, you want to control their anticoagulation, be able to turn it off at a moment's notice, heparin is a great choice. If you have somebody that you don't think is bleeding anywhere else, you just need to give them something to stop the clot from increasing in size, you can give them a shot of something like Lovenox, which is an oxyparin, which is a low molecular weight heparin. It actually is a much more selective version of heparin. It only works at factor 10A. And so it will work, though, for at least 12 to 24 hours, usually 24 hours. And so you give a shot once a day. There is an option of doing a lower dose twice a day, but you give a shot once a day, and those people will have much lower risk of blood clots. Now, the novel or non-vitamin K oral anticoagulations, when they first came out, they were called the novel oral anticoagulants. Then, as we figured out they weren't so novel anymore because everybody was using them, they started calling them the direct oral anticoagulants. The problem with that, of course, is that a lot of people don't like change, so they've now gone back to calling them NOACs by calling them the non-vitamin K oral anticoagulants, because Coumadin, of course, works on vitamin K. So the NOACs, which would be most often rivaroxaban or apixaban, would be given and would stop that clotting. They work immediately. You don't have to put them on heparin before. There are people that can't take any sort of blood clotting medicines. If they're in the ICU, they've had major trauma, and you're like, geez, I need to stop a clot. Sometimes you can actually place an a vena cava filter. In the old days, we called them Greenfield filters, and some old people like me still call them that. But most people now refer to them as a vena cava filter. If you watch 1-800-BAD-DRUG and all the lawyer ads, you'll see that some of them have been known to break apart and cause real problems, but not all. So let's talk about the physiology of clotting. So it starts with the platelets. So usually the platelets are activated by some sort of break in the integrity of a blood vessel. But before that, the platelets are created by something called megakaryocytes. Basically, they're formed in the bone marrow in response to thrombopoietin. The cell membrane is coated with glycoproteins. And basically, these proteins allow that the platelets will stick to things. They'll stick to the walls. And so to really work well, there needs to be something called von Willebrand's factor. And there's varying types of von Willebrand's deficiency or disease, 1, 2, 3. I'll let you investigate that if you're interested. But basically, the von Willebrand's and the platelets work together. And then there's release of thromboxane, and then all the platelets stick together, and a clot forms. So this is a positive feedback. So the more it happens, the more it's going to happen. Generally, this kind of clot is a good thing because if you have a cut in your skin, you don't want to bleed together. You want to clot it up. You want to stop the bleeding. So when the fibrinogen in the platelets activates, it's then converted to fibrin. And then the clotting cascade also kicks in. The intrinsic pathway is clotting factor 12, 11, 10, 9, 10, then prothrombin, fibrinogen, and fibrin. And the extrinsic pathway is 7, 7A, 10, and then prothrombin, fibrinogen, and fibrin. Factor 8 we hear a lot about because that's the factor that's deficient in hemophilia. This is really a cofactor to 10. I think it's very confusing because, you would expect it to be a cascade, 12, 11, 10, 9. But it really isn't like that at all. There actually isn't even a factor 6, just because factor 6 was one of the other factors that had been doubly named, and so they basically eliminated factor 6. So not easy to learn, but to be honest with you, not that critical to really understand either for most of what we do. So there's some normal inhibitions to clotting. Protein C will stop that clotting. If you have a protein C deficiency, that can cause other problems. Antithrombin 3 is secreted and will also provide that normal inhibition to clotting. So factor V Leiden is an interesting factor. It's a genetic mutation in the factor V gene, and basically it makes it so that you increase your clotting. These people are very likely to develop clots. If they get multiple clots, we're going to probably put them on lifetime anticoagulation. They're going to need to know that they have it and that the other people in the family should, also be watched for clotting. But Leiden is a city in the Netherlands, and it's where it was discovered. That's the only reason it's called Leiden. So the clot normally starts to break down once it's done its job. Plasmin will start to break down fibrin and fibrinogen. These, when they're being broken down, actually act as anticoagulants to stop the clot from building up anymore. Interestingly, there is something called disseminated intravascular coagulation, or DIC, is something in which these clots will actually start to be broken down. But the problem is that there's so much anticoagulation effect from the fibrin and fibrinogen that these people will start to have substantial bleeding. So they're clotting some places, they're bleeding other places. And this is a ICU type issue. These people are really sick. So just to review a little bit about the pharmacology, it's not exactly pathophysiology, but I think it's a good way to remember it. Heparin interferes with the function of thrombin. Low molecular weight heparin interferes with factor Xa. Coumadin interferes with the synthesis of prothrombin. And so that's really important because you have to remember that it may be 2 days before you really start to see the effect of Coumadin, and 4 or 5 days before you really see the end of the effect of Coumadin. So Coumadin, or warfarin, so-called because it was developed at the Wisconsin Agricultural Research Foundation, WARF. Warfarin will take 2 to 3 days to really exert its anticoagulant effect. The NOACs, or the novel or oral anticoagulants, dabigatran or dabigatran works directly on thrombin, and then the others, the oxaban drugs or ixaban drugs, work on factor Xa. So if you have somebody who is on warfarin or Coumadin, the prothrombin time is prolonged, right? Because we said that's the thing that it works on, is this prefactor. What else interferes with the synthesis of prothrombin? Well, it's made in the liver. So if you have somebody with liver disease, they're going to have issues with prothrombin, and it will, delay it. The INR for her was a 0.9. That's within the range of normal. We say 1 is normal. That's the normal ratio. But 0.9 to 1.1, a little bit of variation is considered okay. The D-dimer, actually, we used to call it fibrin split products. We now call it D-dimer. But basically, that's exactly what it is. So as the fibrin is degrading, it splits into a couple of different things. Those of you that know a lot about chemistry know about dimers, and there's various types of dimers. But basically, this is a split of the product, and it's easier to measure than the actual anticoagulation or coagulation factors because those are used up. This is a precursor that stays stable in the bloodstream. It's not unlike the C-peptide when we measure for diabetes. That's the proinsulin splits into C-peptide and insulin. So what's thrombocytopenia? Let's break it down. Cyto means cells, thrombo means platelets, penia means deficiency of. So lymphopenia is a deficiency of lymphocytes. Leukopenia is a deficiency of white blood cells. But thrombocytopenia is a deficiency of platelets. Now, obviously, if platelets are involved in blood clotting and you don't have the blood that you normally need to stop interference with the walls of the blood cells, of the vasculature, it's going to leak, and it's going to leak into the tissues. Petechiae are basically sort of pinpoint spots of red that you see. If you take a red felt tip marker and then you dab it all over a person, that's what petechiae are going to look like. Purpura, however, are a little bit bigger. They're going to be basically like if you took an eraser and had ink on it. and did that, and then some various bigger erasers too, because they'll often vary in size. The purpura will often turn a little more bluish too, just because it's not just a pinpoint of blood. It's actually going to break down a little bit more quickly. So ITP and TTP are two examples of when you get deficient thrombocytes. ITP is immune thrombocytopenia purpura, and so some call it idiopathic because idiopathic means we don't know what caused it. And so these people can get purpura or petechiae. And if it's autoimmune, well, one of the things that will boost your immunity, at least short term, is prednisone and steroids. And so we'll sometimes give them prednisone, and that will raise up their platelet count to the point where it's helpful. Now, the normal platelet count's 150 to 450. I don't really start worrying about anybody until their platelets get below 40,000, and I really don't start really worrying until they get below about 20,000. Once they get about below 10,000 or so, they'll start spontaneously bleeding some places, although I've seen people with 1, 2, 3,000 platelet counts that were doing okay. You just hope they don't fall down because they could easily bleed to death. Now, TTP is a very different condition. TTP is most commonly associated with cancers, but TTP is when you have somebody that lacks platelets, but will actually start to clot as well as have areas of bleeding. So it's almost like a longer-term DIC kind of thing. They'll be sicker. Some people get the so-called hemolytic uremic syndrome, where they'll start breaking down their own blood cells, and then they'll try to filter those out in their kidneys and build up excessive amounts of blood urea. But those people are obviously very sick. Sometimes with TTP, they actually need plasmapheresis, which is essentially a type of dialysis, where you'll take off the blood and you'll try to filter it and try to get it to have the appropriate number of platelets. So in DIC, if you check a D-dimer, it's going to be up. Obviously, just regular blood clots are the most common reasons, DVTs or pulmonary emboli. But if you've got somebody that has bleeding and their D-dimer is up, you worry that they have DIC. Certain bacterial endotoxins. This is one of those things when we talked about bacteria. Some of them have exotoxins. These are toxins that they release off the outside of their cells. It just happens. Endotoxins are a big deal because if you give them a bactericidal antibiotic and you're lysing all of these bacteria, they will release these endotoxins, and these people can get really sick really quickly. And that's why when you start a bactericidal antibiotic like, Levaquin or Rocephin or something like that, you have to be prepared that they're going to start to have shaking chills and a drop in their blood pressure. And so basically in DIC, all hell is breaking loose. You can give them platelets and heparin. You try to figure out what caused it, infection, etc. But the survival rate is not spectacular. So what about anemia? So anemia is basically low red blood counts and low hemoglobin. I usually look at the hemoglobin. If it's below 13 in a man, I think he's anemic. If it's below 12 in a woman, I think she's anemic. If it's below 11 in a pregnant woman, I think she's anemic. So this is just a quick and dirty way to remember some things. But if you've got these people that have these numbers, you need to figure out why they're anemic. Most people, the first thought is that they're bleeding until proven otherwise, whether it be from a colon cancer or in their urine or something else. But you try to figure out why they're anemic. Obviously, women of childbearing age, if they're still menstruating and having heavy periods, that would explain it. But you also have to figure out what else might be going on. So they can lose blood. The blood loss is the first thing to think of. They can have destruction of their red blood cells from hemolysis. Certain diseases and conditions will cause them to break down their red blood cells, or they can lack production. You can have some kind of bone marrow suppression from either a medication, from a disease, or other issues. So how do we decide? Well, the first thing we look at is the size of the cells. We look at the mean corpuscular volume. because we know that if they're small cells, well, iron deficiency causes small cells. So that's the first thing we think of when we see small cells. Big cells, well, folate deficiency and B12 deficiency causes big cell issues, macrocytosis. Small cells, of course, are microcytosis. One of the problems is that what happens if you get somebody that has a lot of big cells and a lot of small cells? Well, they might have a normal average, a normal mean corpuscular volume. So we do look at the RDW, the red cell distribution of width, and basically that's a standard deviation. How much variation is there in the size? We can also look at whether or not the body is producing red blood cells, and to do that we would look at a reticulocyte count. And that, is very helpful to decide whether or not the bone marrow is working. Sometimes the person has such profound iron deficiency, usually indicated by a really low ferritin, that they're really just not producing. So you'd have to give them some iron to know whether or not they were able to produce. So again, small cells, low iron, blood loss, inadequate intake is very uncommon for low iron. Other things that can cause small cells, there are some thalassemias. Large cells, B12 folate. Pernicious anemia is actually a very specific type of B12 deficiency in which you lack intrinsic factor. There's something called the Schilling's test. It's not an easy diagnosis to make. Most people, if they have a B12 deficiency, we just supplement it. If you do it orally, if they have the intrinsic factor, they can absorb it. If they don't have the intrinsic factor, it has to be given subcutaneously or IM. And again, if you have a variation in size, the MCV might be normal, and you have to look at the RDW. So the hemoglobin electrophoresis is rarely done. If you think somebody has some kind of a hemoglobinopathy, you can do it, but to be honest with you, I rarely do it. The hemoglobin, fetal hemoglobin obviously occurs in certain conditions, but especially in babies. And so you have alpha and beta chains, and you can actually look at the function and the distribution of those. This is more of a hematologist test, though. The hemoglobin needs iron to be produced, and ferritin is stored in the tissues, and that really is the best way to tell whether somebody has any iron stores. Thalassemia, as we note, is also a sign of microcytosis. I have a couple of people of Asian descent that have alpha thalassemia. They actually have a variation called constant spring, which I find interesting. And then beta thalassemia, if you have people with small cells, almost all of these people obviously are going to be beta thalassemia minor, because if you have major, they've usually died at a relatively young age. African Americans can actually have either alpha or beta. It's an interesting question. If I have somebody with small cells, I'll often refer them to hematology to get a diagnosis. If we get a diagnosis, then they might want to think about doing some sort of genetic counseling, just so they make sure that they don't marry someone with a similar gene. Sickle cell disease in African Americans, also rarely. There's a small group in Canada that get it, which is really interesting to me. Basically, what happens in sickle cell anemia is that it's a genetic disorder in which the cells will sickle. They'll basically turn from being round into these moon-shaped cells. The problem is these moon-shaped cells don't move through the capillaries very well. They hook, they catch. When they hook and catch, they'll actually cause substantial pooling of blood, and people can get really bad joint pain, really substantial aches. It's extremely painful. I've only seen it a few times when I was working in Boston, but mostly I saw it in kids. These kids were absolutely in agony. You really just had to give them a fair amount of narcotics to get them comfortable. And that usually happens when oxygen demand is extreme. There's one of the theories is that it is an adaptive response to malaria, because if you have malaria and your cells sickle, the malaria parasite will be killed, but that's just a theory at this point. So the cells block the arteries, they cause ischemia and infarct at times, so you can actually have loss of toes, and basically the body tries to clear it, it'll develop fever. There's also some hemolytic anemias in which your body is attacking. Not going to talk a lot about the Coombs tests other than to just let you know that they exist, so that if you have somebody that has a substantial level of hemolytic anemia, you'll usually see this because their bili will be up, and they'll be reticking to beat the band, but they won't be able to maintain their cells even though there's no sign of bleeding. And so the polycythemias, these are people that have excessive numbers of red blood cells. And basically with a polycythemia, the first thing you think of is smoking, or they've been at a high elevation. But there are certain cancerous type processes in which the bone marrow is overproducing. Usually these are fairly easily managed with phlebotomies. We're going back to the 17th century and we do some bloodletting for these people. But we take off the excess blood. I have a couple of patients that have a unit a month taken off, sometimes more, sometimes less. But it usually will manage them pretty well, but you just need to know that it exists. So lots of good stuff out there. I think we gave you a little bit of an overview. We'll put some discussion questions and hopefully get a good discussion going.